We're going to finish our discussion on phagocyte defects here. A 3-week-old girl was brought to the clinic because her parents are concerned about some swelling and redness around her umbilical cord stump. She's otherwise well and has been feeding appropriately. She has about 6 wet diapers and 3 soiled diapers per day. She was born term to a G2P2 mother via planned C-section. Birth weight was 7 pounds 9 ounces. Family history is non-contributory. Presently, baby is running a slight fever at 100.4 degrees Fahrenheit, but is otherwise vitally stable. She appears well, is in no apparent distress. She weighs 8 pounds 12 ounces. On exam, you note mild erythema surrounding the intact umbilical stump. Exam is otherwise unremarkable. So what is your assessment here? Just based on how this child's presenting. Don't have to think of underlying causes. How is this baby presenting? What does she have, most likely? So more than likely, this baby has omphalitis. Omphalitis is, well, let's go back even further. She has a delayed umbilical cord stump detachment. Remember that the umbilical cord stump should detach around 1 to 2 weeks of age. What's the umbilical cord stump? Remember that when a baby's born, they have their umbilical cord. You cut the umbilical cord, that last little bit, you take a little tool to that, I don't know what it's called. You take this little tool and it kind of twists it a little bit, and then you tell the parents this thing's going to fall off in preferably under 2 weeks, but usually before that. That little cord of skin, that little stump, it turns black and it just falls off. Now, if that doesn't fall off, after 2 weeks, it's considered a delayed umbilical cord stump detachment. And that is unusual. And it should make you think of a few different things, one of which we're talking about now. Now, we also note that around that umbilical cord, there's some redness and erythema. That tells us that there's probably inflammation. And the fact that she has a fever also tells us that there's probably some kind of an infection going on. Other than that, though, this baby does not appear prima facie to have an immunodeficiency. She hasn't had any other infections. She's growing fine. And so what's going on here? Well, we're going to do our investigation starting out getting blood work. Anytime you've got a baby with a fever, you should be getting blood work, at least a CBC. Electrolytes are normal. CBC is notable for a white count of 58 per microliter. Now, I put thousands here. Anytime you see shorthand, somebody puts white blood cell count of 13, what they mean is 13,000, or 26 is 26,000, or 7 is 7,000. And that's per microliter. So white blood cell count of 58,000 per microliter. The reference range is between 5 and 10. So this is not only a leukocytosis, this is a really elaborate, profound leukocytosis. There's also an elevated ANC, as we would expect to see. She's producing more white blood cells, so she should have a concurrent elevation in her ANC. We also note that the peripheral smear appears normal. That's good, so there's no problems, at least macroscopically or microscopically, with her blood cells. So there's probably not a problem with production, nothing like a leukemia or anything like that. Quantitative immunoglobulins are normal, so that tells us there's probably nothing going on specifically with the B cells. And C3 and C4 levels, part of our complement system, those are also within normal parameters. So we have a baby with omphalitis, and she has a fever, meaning there's probably infection going on, and she's got elevated white count that contributes to our diagnosis of infection. So this is omphalitis. Now at this point, you should know, or you would know if you knew what this diagnosis was, or at least what you should suspect, is leukocyte adhesion deficiency. So why would you suspect leukocyte adhesion deficiency? Leukocyte adhesion deficiency. Why would you suspect that? You would suspect it just based on the fact that there's delayed cord separation and that there's infection around that site. The classic way for LAD patients to present is with delayed cord separation and omphalitis. So, the fact that this baby's 3 weeks old, no separation, inflammation surrounding the umbilical stump, that's omphalitis, delayed omphalitis. And then we have signs consistent with infection. You're going to have to do other tests. You can't just make a diagnosis of leukocyte adhesion deficiency just based on this alone. So what is leukocyte adhesion deficiency? This is a rare disorder. It's autosomal recessive, and it's a condition involving the impairment of normal neutrophil migration to the sites of infection, and it's caused by an abnormality of integrins. What are integrins? Integrins are these cell surface molecules that are expressed on the surface of white blood cells, and they are needed as part of the process of extravasating them into sites of infection where they can subsequently work and then clear the infection. Without these integrins, the body can't respond to infection, and otherwise innocuous infections become much more severe. There are at least 3 known types of leukocyte adhesion deficiencies. For the USMLE, you're concerned about LAD1. That's the most common one in the United States, even though all of these are rare. Type 2 has been noted, but it's only been in the Middle East and in Brazil. I don't believe we've seen it here. So everything we're going to talk about here is pertaining to leukocyte adhesion deficiency type 1. Patients with leukocyte adhesion deficiency typically present early on in life with delayed umbilical cord detachment and omphalitis, inflammation in that area. These patients otherwise don't have the same type of immunodeficiency that you see with some of these other diseases, especially those that relate to B cells and T cells, because there's nothing wrong with their cells, with producing B cells and T cells, with their behavior. The problem is particularly with that ability to extravasate otherwise normal white blood cells into sites of infection. Now, that having been said, let me explain this later because I want to give you some other things here. So, all right, this is how the whole extravasation process takes place. So you know that your red blood cells and your white blood cells and your platelets are moving along in the circulation at a relatively fast rate. And the first thing that happens when there's injury, the first thing that's going to happen to recruit white blood cells, in this case we have a neutrophil, the first thing that's going to happen is that there's going to be an interaction with something called a selectin. And this selectin will slow the white blood cell down. Remember how fast they're moving. If you look at how fast blood is moving through your capillaries, it's pretty fast. So this will slow it down, and it slows it down enough to where you can get firm adhesion. So this whole time when they're bound to the selectins, really it's not bound to one selectin. They're bound to one selectin, it slows it down. They're bound to another selectin, kind of slows it down. So really this is just what's called this rolling phase. Once it interacts with something called ICAM1, you now have a firm bond, a firm adhesion. And what interacts with ICAM1, which ICAM1 is expressed on the endothelium, is something called an integrin. And integrins are made up, as far as we're concerned for white blood cells, they're made up of a complex between CD11 and CD18. And there's various types of CD11, and they, when they interact or when they are combined with CD18 as sort of one complex, they form what's known as an integrin. They're collectively together an integrin. And this is our site of problem here. So your integrin, or CD11, CD18 complex, interact with ICAM1, and this forms a firm adhesion. And once there's a firm adhesion, you can begin the process of diapedesis. And diapedesis is just a fancy word for extravasation, where the white blood cell can then travel into the interstitial space, ultimately to the site of infection. And it's led there by chemotactic proteins. One that comes to mind is CXCL8, formerly known as interleukin 8, which draws the white blood cell down to the infection. All right, so CD18 is where our problem is. And these integrins all are composed of CD18 and then a variable cluster of differentiation protein. So I'm going to concern you with 3 of these here, and that's LFA1, MAC1, and P15095, but particularly LFA1. This is one we're most concerned with. So all of these contain CD18, and then respectively LFA1 contains CD11A, MAC1 contains CD11B, and P15095 contains CD11C. So they're all CD11s interacting with CD18s. You can see, though, if you knock out your CD18, all of these are going to be defected. And so LFA1, the one we're most concerned about, is not going to be able to work. And if you go back here, all of these integrins, if they don't have CD18, you're not going to have any firm adhesion between the integrin and the ICAM1. And so these blood cells are just going to move right back into the general circulation. Now, I will also... Okay, this is just supposed to be funny. I put this in here. So I will also note here that not only is that LFA complex important for ultimately causing extravasation of the neutrophils, but it's also important with regards to signaling between T cells and antigen-presenting cells. So remember that the way that antigen-presenting cells will tell a T cell that they have something that you might want to fight off, the way they do that is by expressing the foreign substance on this MHC class II, which then presents it to the T cell receptor. In order to stabilize that interaction, you need LFA1 and ICAM1 to be interacting appropriately. So you can imagine that a CD18 defect, being that it is part of your component of LFA1 along with CD11A, if that's defected, you're going to have defected interaction between your T cells and your antigen-presenting cells. And so your ability for your T cells to proliferate in response to an antigen is going to be somewhat defected. Now, that having been said, the primary mechanism of immunodeficiency in patients with LAD is not this. Okay, their main problem is with extravasating their white blood cells. However, this exists too. And as you're going to see in some of the tests that we do for leukocyte adhesion deficiency, this actually is reflected. This is omphalitis. So this is the umbilical cord stump. It turns this normal black. This is normal. But notice that there's also this surrounding inflammation. How much inflammation do you expect you're going to see in a patient with an inability to extravasate their white blood cells into sites of infection? Not a lot. Okay, it's very difficult to get a whole lot of inflammation when your whole process of recruiting cells to the sites of inflammation to really have a nice, what's the word I should use? A nice, well, to have a really robust response to infection. All of that is defected. And so you don't expect to see a whole lot of redness, even in sites of infection. You could culture this, and you could get tons of E. coli and Staph aureus from this site of infection, but it's not really going to look like it's got infection. And notably, in leukocyte adhesion deficiency, you're not going to get pus, because remember what pus is. It's white blood cell matter. And so they will have infection, but they won't have as much redness, and they certainly will not have pus. But that shouldn't make you think that this is not a bad infection, because it is. They just don't have all of the cells and everything that are supposed to respond into the site of infection. Okay. So here's another case of omphalitis. In this case, the umbilical cord has been detached, and you still have that redness in the area. Note you also have this kind of nasty material here, but no pus. There's no pus. And anytime you have an infection, especially a superficial infection, you'd expect to see pus to some degree. So for diagnosis, we'll start out with a workup, CBC differential smear. Anytime you're starting out, you're getting a first CBC on a patient with a new infection, you should always get a smear with it. White blood cell counts, white blood cells are going to be characteristically elevated. So why are you going to have an elevation of your white blood cell count? We already alluded to this in our vignette. So you go back here and look at what's going on. You have neutrophils. You have all your white blood cells in your peripheral circulation. If you have an infection, you're going to make more of them, right? You want more white blood cells if you have an infection. That's a normal response. However, what's not happening and what's abnormal here? Your white blood cells are not extravasating into the sites of infection. And so what's happening is you can't get your soldiers to the battlefield, for lack of a better analogy. They're all going to be congested up in the circulation. They're going to remain in the circulation. So while you have a normal proliferation of white blood cells as a response to infection, because they cannot migrate out and get rid of the infection, you're going to have not only an elevated white count, you're going to have an extremely elevated white count because those white blood cells are not leaving the circulation. And that's why we saw such an elevated white count in this patient. So characteristically, your white count is going to be very high, and that is going to help you differentiate this from something like neutropenia, where you can get a lot of the same findings. Think of it. If you don't have any white blood cells, you basically have the same thing going on. If you don't have any white cells, you're not going to get white cells to sites of infection. You get a lot of the same things. Difference is, on CBC, if you have leukopenia, that will show up as low white count. If you have leukocyte adhesion deficiency, that will show up as an elevated white count. On the other hand, the smear should be normal because you don't have a problem with producing cells. You don't have a problem with something like, say, leukemia, where you're going to have abnormal cells in the circulation. That can also cause elevated white count, but your white cells in the circulation will be abnormal. Quantitative immunoglobulins will be normal. That just reflects that this is not a B cell problem. C3 and C4 will be normal, reflecting that this is not a complement problem. Now, if you do mitogen response testing in a patient with leukocyte adhesion deficiency, which we might because we want to see if this is possibly a T cell issue. At this point, let's say we don't know. You can do mitogen response testing to see if you have a normal response of either T cells or B cells to an antigen. And what we're going to use here is phytohemagglutinin. You could also use something called concanavalin A. Both of those are supposed to stimulate the production of T cells. Now, going back, remember that the way we stimulate T cells, if we're going to present them with an antigen presenting cell, what we need to be able to do is have a stable interaction with the T cell and the antigen presenting cell. And this is how that interaction goes on. Now, if LFA1 is gone, because we don't have CD18, we are not going to have prolonged cell-cell contact. And so our response to this mitogen, this antigen, which in this case we use phytohemagglutinin, the interaction is not going to be very long. And so our T cell response compared to normal is going to be blunted. And that is why you have a depressed mitogen response to phytohemagglutinin. All right? That is just all this is saying. It's not saying there's anything wrong with the T cells. All it's saying is that you don't have a long enough T cell APC interaction to get the same kind of response that we would get in response to the mitogen. We don't get the same kind of response as we would expect. And that's just reflecting the CD18 mutation, which causes the LFA a problem, which is ultimately resulting in abbreviated APC T cell contact. And that's going to affect our ability of our T cells to proliferate. Now, another test you can do is flow cytometry. And here we're just measuring specific clusters of differentiation, or CDs, that exist on each type of cell. So for B cells, the specific one is CD19. For T cells, CD3, CD4, CD8. And for natural killer cells, it's CD16. We would expect with leukocyte adhesion deficiency that we would have a relatively low CD3 count compared to CD16 and CD19. Why? Because, remember, we don't have appropriate T cell proliferation. I want you to know, though, that is not the primary means of immunodeficiency for these patients. The primary reason these patients are immunodeficient is that they don't get white blood cells to sites of infection. It's really not so much due to their T cell problems, but that doesn't help, but that's not the primary mechanism of their immunodeficiency here. But it is something that we can look for on labs that help us making a diagnosis. So your CD3 will be relatively low compared to CD16 and CD19. If you were to measure the Cd4 and Cd8, though, which are specific types of T cells, your Cd4 and Cd8 ratio would be normal because you're making T cells appropriately, you're just not able to proliferate them as you should. If you get a CD18, remember CD18 is our site of mutation, our This is the basis of our problem here. If you were to look for CD18, that would be very low compared to CD3. And CD18 and CD3 should be roughly equal. So a low CD18 compared to CD3 is consistent with a diagnosis of LAD type 1, and a low CD11A is diagnostic, because remember, CD11, be CD11B, CD11C, CD11A, they are all expressed along with CD18 on your neutrophils. Now there's another test that can be done, but it's not done hardly at all anymore because flow cytometry is used so much. But I've seen it come up a total of once on all the thousands of USMLE questions I've ever looked at. And that's called the Reebok skin window. The Reebok skin window, this is kind of nice because even though this disorder is rare, this is a good test because it really gets your mind thinking of the physiology here. So what a Reebok skin window is they take a little kind of dull scalpel, dull scalpel, and they abrade some of the skin on the forearm. And what that does is it denudes a little bit, it sort of denudes the forearm to where you should get some white blood cells migrating there because you have minor trauma, and white blood cells should migrate to that site. And what they take is a sort of cover slip. I don't know if it's like a sticker or what exactly it is. I've never seen the test done. But anyway, they take this little slip and they hold it over that area for 2 hours. And what you would expect to see are white blood cells, of course, because you've damaged this area, and now we expect to see leukocyte migration to that area. In a normal patient, you will see white blood cells, a certain number of white blood cells. In a patient with leukocyte adhesion deficiency, you wouldn't. All right, that's Reebok skin window. I don't think we do it in practice anymore, but that was classically the way this was tested for, and now we have flow cytometry. And as you can see, since we're directly testing CD18, it's a much, much more accurate test. The management here is pretty much just bone marrow transplant. Fortunately, it is a lot easier to do bone marrow transplant in these patients. However, that is really the only way we have to treat them, and that's unfortunate because sometimes it's hard to find bone marrow transplants for patients, especially if they don't have any siblings or the parents, maybe one of the parents isn't in the picture or they're adopted or something like that. So bone marrow transplant is the only cure, and if they don't get bone marrow transplant, they're likely not going to survive too long. Prophylactic antibiotics and interferon gamma, while they are used in some of the other immunodeficiencies, they have no place in leukocyte adhesion deficiency. Nevertheless, if a patient has an infection, you should be treating them aggressively with antibiotics. Usually we're going to have to treat them longer, and what you might have done orally in a normal patient, you'll have to do IV in an LAD patient. But bone marrow transplant is the definitive treatment, and typically this is what is done for most patients. And it is curative.